to the power minus 1. Okay, but normally, more commonly, SVR is expressed in CGS unit, that is dynes per second per centimeter to the power 5. সেটা কি করে হয়? Because 1 millimeter mercury means 1330 dynes per square centimeter. Okay, and cardiac output will be expressed as centimeter to the power 3 per second. That's 5 liter per minute. So in CGS unit, it will be centimeter gram second. So centimeter to the power cube per second. So if you ask me, I mean, the SVR will be expressed in the dynes in the CGS unit. It will be dynes per second per centimeter to the power 5, isn't it? Is it clear? Why centimeter to the power 5? See, MAP minus CVP by cardiac output, তাই তো? এটা আমরা এক্সপ্রেস করছি মিলিমিটার অফ মার্কারিতে, আর এটা আমরা এক্সপ্রেস করছি এতে, তাই তো? এবারে মিলিমিটার অফ মার্কারি যেটা, সেটাকে আমি রিপ্লেস করছি কি দিয়ে? ডাইন্স দিয়ে, ডাইন্স পার স্কোয়ার সেন্টিমিটার, সিজিএস এ গেলে আর কি। সো ইট উইল বি ডাইন্স পার স্কোয়ার সেন্টিমিটার। বেসিক্যালি স্কোয়ার সেন্টিমিটারটা এখানে চলে আসবে তাহলে, তাই না? বাই করলে তো নিচে চলে আসবে, ডাইন্স পার স্কোয়ার সেন্টিমিটার। আর তার সাথে এখানে তো কার্ডিয়াক আউটপুটটা এখানে আছে এরকম, সো ইট উইল বি কিউব সেন্টিমিটার পার সেকেন্ড। তাহলে এটা কি হলো? সো ইট উইল বি ডাইন্স, তাহলে হলো সেন্টিমিটার টু দি পাওয়ার 5 ইন্টু সেক, তার মানে হলো গিয়ে ডাইন্স পার সেকেন্ড মাইনাস 5, 2 plus 3, না, dynes by second. See, millimeter of mercury means dynes per square centimeter. Okay, so dynes by square centimeter. Okay, so that's my dynes by square centimeter, like this. Dynes by square centimeter. তার সাথে কার্ডিয়াক আউটপুট, বাই কার্ডিয়াক আউটপুট তো আছে নিচে, তাই না? সো কার্ডিয়াক আউটপুট ইজ এক্সপ্রেসড অ্যাজ সেন্টিমিটার কিউব বাই সেকেন্ড। সো ডাইন্সটা হবে তাহলে সেন্টিমিটার 2 plus 3, 5 by second. So dynes per second per square centimeter to the power 5 minus 5. Got it? How is derived? Just change the unit. It was millimeter of mercury by that one. ml per minute we are expressing as centimeter cube by second. So normal SVR is like this, 900 to say 1440. Is it clear? MAP minus CVP by cardiac output. That's the crux. So the calculation will come in the dynes per second per centimeter to the power 5. Is it clear? Okay. So this is SVR. So now, tell me, what will happen if there is vasoconstrictions? If the vessel constricts, there will be vasoconstrictions, vessel dilates, it will be vasodilatation. So what will happen to the SVR? If there is vasoconstriction, what will happen? Resistance will increase. And if there is vasodilatation, SVR will get decreased. So very important. Now come to the shock. Okay. Acha. Regarding the resistance, there is one formula. What is this? HP formula. Physics 11, 12. What's that? Hagen-Poiseuille's formula. What does it say? What is this? R for resistance. 8 ln. What is L? Length. What is N? Viscosity of the fluid. Pi into R to the power 4. R is, this R is radius. Okay? Okay. So, more, see, this is the length and this is the length. So, if I squeeze again, squeeze from this end, if I squeeze, the upper or the lower, where I need more resistance? Where I will feel more resistance? The lower one. Because I have to press longer to reach there. So, as the length increases, the resistance will be more. This one, where the resistance will be more? The upper one or lower one? Upper one, because it's smaller. So, I need more resistance. If it is a bigger, quickly it will come out. Huh? So, resistance will be more in the constricted one. And if the radius is x and this is 2x, the change of resistance will be to the power 2 to the power 4. This is x radius, this is 2x, that means double. Okay. So, resistance will be R to the power 4 to 2 to the power 4. So, 16 times. If the vessel radius is halved, the resistance will be 16 times higher, because this is a mathematical formula. And N is the viscosity. Say, through it, if I want to eject, in one scenario is water and in one scenario is honey. Which will require more force? Honey. Because that's more viscous. It don't come out easily. So I need more pressure, more squeeze, isn't it? So more viscous, more we need, more the resistance I will feel. Okay? So this is the basics. This physiology you must know. Okay? Now come to the pathology. So what is shock? In one word, what is shock? What is shock? Okay. Okay. Hypoxia of the tissues. That is the most important. Whatever may be the cause. Oxygen metabolism by oxygen dynamics se prothomei bollam je cell needs oxygen. Okay. So that's the thing. Shock is state of cellular or tissue hypoxia. That may happen in different way by reduced DO2. DO2 means oxygen delivery. So reduced DO2, or it can happen increased oxygen consumption by the, why the cell is taking increased, extracting more oxygen, because he is not getting enough. So he is trying to extract more. So shock may be because of reduced delivery or increased oxygen consumption, or oxygen has been provided but the cell cannot use the oxygen. So inadequate oxygen utilization or combination of any of these. So combination of any of these can produce a state of cellular hypoxia. So shock means hypoxia at the cellular level. That's the most important thing. Whatever will be the way. Inadequate cellular supply of cellular oxygen. That may be because of inadequate supply or inadequate utilization, or maybe increased extraction. Okay. So most commonly it will be manifested as hypotension. Most commonly, it's some circulatory failure, hypotension. That is the most common. But remember, patient in shock, they may be hypotensive, they may be normotensive also. Sometimes even they may be hypertensive also. Shock has different stages. I will take it in the next class. Different stages. Okay. So everything can happen. Shock doesn't mean hypotension every time. That is the most common presentation, hypotension. But a patient who is normotensive can have shock. Okay? Because shock has different stages. That's the on next lecture. Okay? So that is very important. You must remember, a patient, hypotension is the most common presentation, but a patient of shock may be normotensive, even hypertensive also. Okay? So normal BP doesn't exclude shock. If I ask the take home message from this slide, there are two lines. Shock means state of cellular hypoxia, and second, normal blood pressure does not exclude shock. These are the two most important lines of these slides. Okay. Because shock has different stages, compensated, uncompensated. Even in compensated stage, patient may look normal otherwise, parameter wise, but not at cellular level. Okay. So, why shock is important? Because effects of shock, they are initially reversible. But if you don't intervene in this stage, it will rapidly become irreversible. Irreversible means there will be multi-organ dysfunction, failure, eventually death. Okay, death of the cell, more cells die, more organs will fail, ultimately the patient will die. Okay. So when a patient presents to you, that time she is an undifferentiated shock. Your job is to identify what type of shock it is. You have to start therapy that way. You have to reverse shock, and you have to prevent multi-organ failure, and ultimately you have to prevent death of the patient. Okay. So now what are the types of shock? What are the types of shock? This is okay, clear? Okay. Now, what are the types of shock? These are the 4 types. Distributive shock. What are the examples of distributive shock? 2 or 3. One I have already written. Septic shock. That is the most common type of distributive shock. Okay. Another example. Anaphylaxis. This is also a type of distributive shock. Then next common is the hypovolemic shock. This is the most common. This is the second most common. Then the cardiogenic. Then the obstructive shock. Okay. Now, what are those? This is a normal situation, normal. Now, if we talk about hypovolemic shock, this is a normal situation. Just remember heart, artery, big arteries, arterioles, venules, big veins. Okay. This is the normal one. So now if I talk about hypotensive shock, who is at failure? How it happens? This is the heart. What is the normal cardiac output? 5 liters. Okay, 5 liters normally. So hypotension means 5 liter cardiac output. It is a hypotensive shock. Suppose there is a road traffic accident. What do we do? Normally we lose blood. That may be from here, that may be from here, that may be from both artery, vein, है ना? So some blood will be lost. Some blood will be lost from here. So suppose if we lose, say 2 liters of blood, some road traffic accident, we have lost 2 liters of blood. Okay. So now what will be the effective blood volume from 5 liter to কত হবে তাহলে 3 লিটার হয়ে যাবে তাহলে so this is a normal situation, this is a normal condition, so there will be 5 liter of cardiac output, but if I lost 2 liters is out, so the effective blood volume will be 3 liters. So hypovolemic means there is some volume loss. That is usually blood, but it may not be blood also. What are the other mechanisms by which we can lose fluid? What are the other mechanisms by which we lose fluid? Vomiting, diarrhea, because we have volumes, we have water also, no? So majority, I mean, if we have more bowel movements, so some good amount of fluid will be lost. If we vomit, in that way also we can be dehydrated. We lose our blood volume is okay, but we are losing fluid. We get hypovolemic. So there is a water balance also. So most commonly hypovolemic shock is because of bleeding, but also it can happen with vomiting and diarrhea. Okay. Suppose some patient has intestinal obstruction, or some patient has acute pancreatitis. Okay. Each of them will be, I mean, may cause hypovolemic shock in a different way. Road traffic accident, just because of loss of blood. Acute pancreatitis, because of the third space loss. When I will, take class on acute pancreatitis, I will teach that. It will be a third space loss. Okay. Water from the vascular compartment will leak to the extravascular space. That won't be available to us. Okay. So if blood is less, 3 liters, what will happen to the preload? What will happen to preload? What will happen? Blood volume 3 লিটার হয়ে গেছে, আরে কমনলি কি হবে? প্রিলোড কি হবে? কমে যাবে। So less blood is available, so less blood will reach heart. So what heart will do? Heart will try to maintain its cardiac output. That's the, by nature, body will try to maintain homeostasis. So what will be the response then? Then how heart can achieve this goal? Yes, because stroke volume will be less blood is reaching. So with each contraction, less blood will be pumped. So heart will increase the rate. So clinically it will be like, if we see the pulse, it will be tachycardia. Okay. So this is the hypovolemic shock. Volume loss, volume failure. Okay. Now, what is cardiogenic shock then? What is cardiogenic shock? The name suggests itself. Oh, কোথায় চলে গেল? Stroke volume depends on preload, contractility, afterload. So now who is at failure? Contractility is failure. So who is responsible? The heart. Suppose a patient has AMI. Okay. So the heart is the culprit. Who is the culprit? This is the culprit. Heart. If it can't pump adequately, how will you have? What will have? Blood won't reach the circle. In the aorta, it won't reach the organs. The cells won't get oxygen, isn't it? So the cardiogenic shock means the heart is at fault. So it's the failure of the function of the heart. That may happen if you have AMI or if you have tachyarrhythmias, okay? Some patients are having ventricular ectopics, okay? Ventricular tachycardia or atrial fibrillation where the heart, have you read it in physiology, atrial fibrillation, have you heard? Atrial fibrillation, that means heart rate is too high, there is no effective contraction, okay? So any tachyarrhythmias, any AMI where the heart muscle has gone, so they won't be able to pump adequate amount of blood, okay? So that's the cardiogenic shock, okay? Now, what is distributive shock? What is distributive shock? Heart is okay here. But if you see, this is a normal thing. This is a distributive thing. কি ডিফারেন্স দুটোর মনে হচ্ছে? হ্যাঁ, কি ডিফারেন্স মনে হচ্ছে? Dilatation. There is excessive dilatation, vasodilatation here. Okay. So what will happen to the SVR? SVR will be very low. Huh? So distributive shock main these are capacitance vessels, no? There will be peripheral pooling of blood. Huh? So there will be much dilatation, peripheral dilatation. So everything will be pooled here. Okay, everything will be pooled here. মানে P-double-O-L-E-D, pooled, not pool, P-U-L, P-U-double-L, not that. P-double-O-L, pooled. So everything will be staggered here. Okay. So the SVR will be less in distributive shock. Okay, fine. So that is the distributive shock. Typical example is septic shock, also happens in anaphylactic shock and some neurogenic shock also. And the last one is obstructive shock, which is most rare. I mean, among these four, there is the rarest. So what is distributive shock? What is obstructive shock? Where is the obstruction? Where is the obstruction? What is this? Have you heard of venous thromboembolism? What's that? What's that? What is this? Have you heard venous thromboembolism? Where does thrombus form normally? First, legs, very common. If you are immobile, very commonly there is leg thrombus, which can dislodge and go to pulmonary artery. So what will happen if some thrombus is lodged in the pulmonary artery and it blocks the way of pulmonary artery? So even if heart pumps, will it be able to pump blood to the lungs? Will it get oxygen then? No. So that's the obstructive pattern. That's the obstructive shock, pulmonary embolism. Or even if heart is in a pouch, it's called pericardium. So if there is some fluid collection in the pericardium, it will have which effect? In a medical term, tell me. Suppose heart is in a pouch, pericardium. if there is some collection, some fluid in the pericardium, effusion, okay, fine. The effect is the tamponade effect. Okay, so pericardial tamponade. If the pericardial tamponade is there, heart won't be able to pump. So these are the features of the obstructive shock. Okay, so this is the main 4 types of shock. So distributive shock, most common. Classic example is sepsis. Also happens in anaphylaxis. Sometimes also neurogenic shock. Second most common, hypovolemic shock. Third, cardiogenic shock. Least common, obstructive shock. Okay. So who are at fault in hypovolemic shock? Who is at failure? The volume. In cardiogenic shock, who is the culprit? Heart. In distributive shock, who is at fault? The system, the pipe system, vasodilatation, less SVR. That's most important, less SVR, because of the vasodilatation. Okay, so there is pulling and obstructive. So the outflow of the heart, okay, that may be in the pulmonary artery or maybe the heart itself, because heart is in the pouch. So if there is tamponade, heart cannot pump. Okay. So these are the basic 4 types of shock. Clear? So now, if I look at it, distributive shock, there is vasodilatation, both arterial and venous. This is the normal, this is the distributive. Okay. So because of this pulling, there is relative inadequacy of intravascular volume. Okay. Cause sepsis, anaphylaxis, neurogenic. So blood pools in the venous capacitance vessels. Veins are more capacitance vessels. Yeah? Capacitance vessels are mostly vein. So if they dilates, they will have good amount of blood pooled in them. So there will be relative preload ki habe. Again, preload will come down because blood is pooled there. Okay. So hypovolemia, so volume is lost. So decrease intravascular volume. It will reduce preload, ventricular filling and stroke volume. Cardiogenic. So there is reduction in the cardiac output because primary cardiac disorder. Okay. And obstructive. They interfere with filling or emptying of the heart or the great vessels. Some mechanical factors like as I told you. Okay. So now if you see this thing, arterial pressure is blood pressure or the mean arterial pressure is cardiac output into SVR. Okay. And cardiac output depends on stroke volume and heart rate. Stroke volume depends on preload, afterload, contractility. So in hypovolemic, typically preload is less. Cardiogenic, typically contractility is less. Obstructive, somewhere here it is, impaired. And distributive, that is vasodilatory. So that means SVR will be at fault. So SVR will be much less. Okay. Stages and this thing I will take on the next class. So read these things, get very concepts clear. So if I ask you, stages and clinical features are in the next one. But still, just still I have time, 5 minutes. So their initial compensatory, okay, then progressive, then irreversible. This is the stage where in the compensatory stage, patient may look normal. That means BP may be normal. When it's progressive, definitely BP will fall. And irreversible means in spite of the support, you cannot jack up the BP. Okay. So very early signs, of shock will be increasing because at the cellular level, the changes have have started at the cellular level. So what is at cellular level? the metabolism is changing from aerobic to anaerobic. Once it's anaerobic, it starts accumulating lactic acids. So a patient may look normal, okay, the BP may be normal, but if you do the ABG, arterial blood gas analysis, lactic acid will be more. So in a sick patient, you always, that's why you ask for an ABG, arterial blood gas analysis, okay. So if I see that lactate is more, that means something is not right at the cellular level. That may not be evident in the blood pressure or this thing, but something is at fault at the cellular level. Okay. So progressive means when the compensatory mechanism fails, and irreversible means obviously there is organ failure then you cannot revive the patient. So you know the basic, what are the basic pathophysiology of the 4 types. So in one word, if we express like this, distributive means vasodilatation, no, this is dilatation, so SVR will come down, so low SVR. So what is the cornerstone of therapy? What will be the cornerstone of therapy? What you have to give? Vasopressors, so that the, vasopressors, okay, so that the vessel constricts and SVR rises. So cornerstone will be vasopressor. You have to give IV fluids, everything. If you have sepsis, you have to give antibiotics, everything. But the cornerstone, you have to revert this pathology. You have to give vasopressor. Okay. So if someone gives you an MCQ, say what is most important for treating this thing. Apart from all these, vasopressor is a must. That's the first thing. Okay. You have to give fluids and antibiotics as an adjunct. So hypovolemia, that means main problem, preload is less, so there will be low CVP. So you have to give fluids, and if it is a hemorrhagic, then you have to give blood. Okay. Cardiogenic, there is low cardiac output. Heart is at fault. So primary therapy will be inotropes, which increases the contractility of the heart, not vasopressors, contractility of the heart, inotropes. And obstructives, you have to identify the cause. Say if it is a pulmonary embolism, you have to do an embolectomy, or if it is a pericardial tamponade, you have to take out the fluid or so remove the cause, identify the cause and remove the cause. But in nutshell, this is the primary problem of this type of shocks, and this is the cornerstone of therapy. So next class, it will be stages of shock, clinical features of shock, and the treatment. Okay, is it clear? So be conceptual and try to solve some of the MCQs on shock. Okay. So there are different platforms, so that will, once you try to answer those, it will say, I always say, read Emily type books. Emily type books, if you try to solve, they are very much conceptual. The questions, they are very much conceptuals. There are basic difference in the Indian types of exams and the US Emily type of exams. Indian exams are more likely, memory based. What is the most common, which are least common, this is this. But usually Emily type questions, they are more concept based. There is a usual clinical vignette. These days India is also changing, but if you try to solve US type of questions, conceptually it will be better. Okay.